ABG is a very, very light topic. It's really need an exercise more than only understanding, okay? And we will take it twice in this course with the pulmo as well as with the nephrology, with the renal, okay? So master it from now, you will relax later, inshallah, okay? Those are the objectives for the lecture, okay? So what are the indication to do an arterial blood gas, okay? So really we can lump them into two major indications. The first is assessing the degree and the type of respiratory failure. And to remind everyone, we have two types of respiratory failure. النوع الأول hypoxia type 1 والنوع الثاني hypercapnia, that's meaning CO2 retention, okay? So we can establish the type as well as the degree, the severity of the respiratory failure. And the second reason is accurately measuring the acid-base status, okay? So when you do an ABG, you will get a similar paper like this, and different hospital, different machine will bring a different results. But yani, hold your ground and don't freak out by how many numbers here. Know what you are looking for, you will relax, okay? So for example, if we are looking for the ABG, we clearly see in the blood gas 1, the pH here, so it's 6.9, it's very acidotic. We can also see the PCO2, so the CO2 is 155. This is triple the normal level, as well as we see the oxygen here is 35, so they are very hypoxic, as well as we can see the bicarb here, the HCO3 is 22, okay, so it's close to normal, okay. The rest, it's good to have it, but don't rely on it heavily, okay. The beauty of the arterial blood gas and the venous blood gas is you can get the results very quickly. Usually you will have the machine in the emergency department or in the ICU. So you'll have it instantly. In a minute, you will have your result instead of sending it to the lab. So you can see the potassium, sodium, calcium, glucose, lactate. So it's good to know them, but don't rely on them heavily. If the clinical course is not suggesting, let's say, an elevation in the lactate and the result of the lactate is 15, don't rely on it and send it to the lab, as well as the hemoglobin. So we have a lot of results, but for the sake of today's lecture, we're going to focus on the basically pH, CO2, bicarb, and oxygen, okay? Okay, so this is the buffer equation, very famous. I'm pretty sure you guys took it in the biochemistry as well as last year in medicine. So we have the CO2 with the basically water with this enzymes go basically to eventually to proton and bicarb, okay? So whenever there is, and we always like to reach a balance between those four, okay? So whenever we have something here is in balance, for example, elevation in the CO2, this will actually shift it toward the right side, and the other way around is true. So when we have, for example, an elevation in the bicarb, we're gonna try to get rid of it through the CO2. Okay, this is a nice illustration for the blood gas in a form of a diagram, okay? Just to understand the mathematics relation between the three components. So here we have the arterial CO2, here we have the pH, and here in those two angles we have the bicarb. So for example, let's take metabolic acidosis an example, and let's say the human sample you are taking is here. Here, for example, so you will see that when the metabolic acidosis, of course, we will have an acidotic blood. The bicarb level will be low, as well as the CO2. Let's take another example, for example, chronic respiratory acidosis. So in the chronic respiratory acidosis, it's going to be acidosis still, so the blood pH will be low, while the CO2 usually it's going to be elevated, while the bicarb also going to be elevated. So you see it here at 40. After the lecture, have a look in the diagram. I think it will make a lot of sense what the relationship between those three components. Someone is raising their hands. دكتور في ناس ينتظرون إذن الهوست. Who is the host? I thought I am the host again. Okay, I'll meet them all. معليش بتعبك يا فارس مرة ثانية. أين أنت؟ عادل، عفوا عادل، ما أدري ليش أنا ملزم على فارس. طيب make host. طيب okay, عادل is taking over as the host. الله يعطيه العافية. Okay, so I'm pretty sure you guys took this differential diagnosis for respiratory acidosis. So really the causes are here. It's really decrease in the respiratory stimuli, whether through anesthesia, drug overdose, opioid in particular. It can happen with COPD. It can happen with pneumonia and with atelectasis. Those are very nice illustrated symptoms. So you can see this gentleman is looking drowsy, maybe dizziness and disorientation. You will have hyperreflexia and muscle weakness. And those are the symptoms usually they're going to come up with. And don't forget, the respiratory acidosis may lead to hyperkalemia and eventually to cardiac arrest. Okay. The second type is the respiratory alkalosis. So the causes are basically hyperventilation. Okay. So it can happen with anxiety, with fear, as well as with PE or with mechanical ventilation. Usually they are very irritable individual, can lead again to a seizure, as well as tingling in the extremities. And the alkalosis may lead to hypokalemia, which have its own negative consequences. Okay. Okay. So now let's talk about the main topic, how to approach ABG, okay? So, 5 steps approach. The first is to identify the primary acid-base disturbance. Is it acidemia or alkalemia, okay? And this is rely on the pH in the sample, okay? And the way you're going to see it is to see which major disturbance happened, whether it happened in the CO2 or the bicarb. That's the third step, عفوا. So the first step is acidemia or alkalemia. The second, to find out whether it's acidosis or alkalosis, and you're going to know that by the disturbance in the CO2 and the bicarb, okay? Then you have to find out whether it's metabolic in nature, i.e. initiated by the change in the bicarb, or respiratory, which initiated by the change in the CO2. And we'll take example. I think بالمثال يتضح المقال. Okay. So today let's focus على respiratory because we are still talking about respiratory and pulmonary. Okay. So when you have respiratory alkalosis, so whenever you have respiratory, the primary change is actually in the CO2. Lung CO2, okay? So when you have a respiratory alkalosis, for example, from an anxiety or panic attack, you will have low CO2. So the primary change is gonna have low CO2. You're washing out your CO2 with the hyperventilation. This will lead to decrease in the bicarb, okay? In a chronic, it's gonna have in a ratio of 10 to 5. In an acute, 10 to 2. And different reference will have a different cutoff, but the idea is the same. With a chronic, you will have a profound, significant change in the bicarb comparing to the acute. So you will see some of the references mentioning 5 and the acute 3, sometimes 4 and the acute 2. But the idea is what's the clinical context and whether it's a profound change or mild change, because you need time to have a significant compensation. In the respiratory acidosis, for example, with CO2 or with opioid overdose, you will have a CO2 retention. CO2 retention. This will lead to compensation in the bicarb in the form of elevation. So in the chronic, going to be 3, like 10 to 3, and the acute, it's going to be 10 to 1. Are you guys with me so far? This one, this slide, it's one of the important slides in this lecture, okay? So the first things we did before this is to identify the primary, whether it's acid-base disturbance, whether it's acidemia or alkalemia. That's first. The second is to check the compensation, okay? The third is to calculate the anion gap, okay? And by now, you guys all should be familiar with the anion gap. It's basically the sodium minus the chloride and the bicarb, okay? So let's jump to examples. And I really believe in the acid base, it's really doing more examples, doing more case study, okay? Okay, so 55-year-olds came to the emergency with 2 days history of shortness of breath. His past medical history is COPD and heavy smoker. On examination, he looks ill, tachypnic with a mild hypoxia. His saturation is 86%. His ABG was done, showed the following. So we'll take it one by one, huh? His pH is 7.29. What's that indicate? Acidemia or alkalemia? Acidosis. Good. Excellent. Okay. Partial oxygen is 88, so low. The CO2 is 60. Know that the normal level is 40. So we have CO2 retention, okay? And the bicarb is 26. So we have 20 change in the CO2 while we only have 2 in the bicarb. Is this a chronic or acute? So remember, we have the normal is 40, we have here 60. The bicarb, the normal, let's say it's 26, 24, now we have 26. Okay, acute. Let's go back and measure the compensation, huh? Okay, so we are here in the respiratory acidosis. We have 20 in the CO2, and we have 2 in the bicarb. So it's really acute process. Okay, are you guys following? So we have acidemia, we have profound change. Okay, someone is saying no. Okay, that's okay. So the first step is we figured out that it's actually acidemia. It's not alkalemia, based on the pH of 7.29. And then the change in the CO2 was more profound than the change in the bicarb. We have 20 change in the CO2 comparing to only 2 in the bicarb. So it's likely initiated by the CO2. So it's respiratory acidosis. And the 20 rise in the CO2 was compensated by 20 millimole rise in the bicarb. This is an acute respiratory acidosis. Are you guys following? It's really a work of math. Okay, let's take the second example. You guys, I see yes and no's, and then So far, I didn't hear anything. No, about the acute and chronic. Okay, so if this bicarb, instead of being 26, it is 29, okay? So the rise from 24 to 29 is 5, right? So that indicates chronicity. So that's meaning it took time for the bicarb to compensate. Change of 5 or 2, chronic or acute. So in acute, you will see change in the bicarb by 2. لأنه عندنا هنا 20 ف10 10 1 1. While in the chronic, you will have, based on this, you will have 6. So it will be around 30. Okay. But again, in practice, it wouldn't be exact, but it would be close to that. Is this clear, guys? Let's take another example. Okay. So this is another example without stem. Okay. Yeah, I think we talked about lactate and the hemoglobin and the electrolyte. Just to tell you about the other findings, it might be useful in ABG. Okay, so what's the correlation? This is a common question in practice. When to do an ABG and when to do the VBG. And the reason why people asking that, ABG, it's more painful to patient. So we usually only do it when we have to do it, okay? While the VBG is basically taking a blood from a venous sample. So it's really have almost no pain, okay? So in general, ABG is actually more accurate than VBG assessing the oxygen. It's actually the VBG, you cannot assess the oxygen with VBG, okay? So to have an accurate assessment for oxygenation, you will have to do ABG. While the VBG, it's a reasonable to measure the bicarb and the pH and the CO2, okay? You need just to adjust the finding. And this is very useful in practice. That's meaning when you do a blood work, you can ask for the VBG if you are interested in the gases, not the oxygen. If you are interested in the oxygen, you will have to do an ABG. Do not do a VBG to assess oxygenation. Okay, second example. 55-year-old male presented to the emergency with 2 days history of shortness of breath. Past medical history significant for COPD and heavy smoker. Looking ill, tachypnic, mild hypoxic, saturation is 86%. ABG showed the following. So pH 7.37. So still in the acidemia area, okay? It's not profoundly acidotic like the other one, but it's still toward acidemia. Oxygen saturation is, sorry, a partial oxygen level is 60, so this is hypoxia. Look at the CO2, it's 60 again. But look at the bicarb, it's 30. So is this acute or chronic? Yeah, I kind of burned this question actually. I forgot that that was the second example. But you guys see the contrast here. The clinical presentation is the same, okay? But really the ABG determined whether this is actually acute respiratory acidosis or chronic respiratory acidosis, okay? So acid base is within normal range, but leaning toward acidemia. Change in the CO2, again, more profound than the bicarb. So that's meaning likely initiated by the CO2 rising. This is the respiratory acidosis. The 20 millimercury rise in the CO2 was accompanied by 6 millimole per liter rise in the bicarb. So this is chronic respiratory acidosis with hypoxemia. Okay, example 3. 26-year-old female, pregnant, seeing her OB-GYN for antenatal care. They did a VBG part of the workup and showed the following: pH of 7.48, oxygen saturation is 44. Sorry, partial oxygen is 44, CO2 of 35, bicarb of 21. Okay, let's take them one by one. Is this acidemia or alkalemia? Okay, true. This is alkalemia. Okay. Is the change in the CO2 or the bicarb more profound? So we have 5 and we have 3. Okay, it's between them, but I would say still the CO2 is 35, so it's 5-digit change comparing to the bicarb. Okay, so I think it's still within the respiratory. Okay. Is this acute or chronic? So we have 5 change in the CO2 with 3 in the bicarb. We always can go back to this slide. You are guessing right, okay? Because half of the 5 is half of 10, so half of 1 is only 1, but this patient changed from 24 all the way to 21. And don't forget that pregnancy can actually cause chronic respiratory alkalosis. And pay attention that we are completely ignoring the low partial oxygen because it's a venous sample, okay? This was actually a VBG rather than an ABG, okay? Okay, guys, time for question. Any question, guys? You really have to do exercise with ABG, really to learn it and master it. I wish this is actually not a lecture. This should be like a tutorial to learn more about ABG. But there is tons of material you can find to learn about ABG and do على قولتهم hands-on experience. Any question, guys? Is it clear? Okay, I can't understand the chronic or acute. Okay, that's good question. So the body, we said in the beginning that we need a balance in the body. We need a balance between a CO2 or bicarb. Always understand that. We need a balance between the two. But to reach this balance, you need time. So in the chronic, you will see that the bicarb compensation took time to reach that balance, okay? And really, in a certain condition like pregnancy, for example, you have the time. It's more than 24 hours. She's gonna be pregnant for 9 months. So it's a chronic process, and this is why she had the time to reach that balance. But in numbers, and instead of going only by 2 in an acute, you go by 5. It's just a matter of time to reach the compensation. And the time is what makes it chronic. But really, when you encounter a case, even in real life, you will have to do the calculation to know whether it's actually acute or chronic. Because like the example we encounter, the COPD, they may have it chronic, but sometimes they will have it actually acute. Okay, any other question? Is it related to time? Is it related to time to say chronic and acute? Yes, it is related to time to become chronic, okay? And we can see this evidence by doing the calculation. Someone asked about calculating the access gap. Well, you take the sodium وتنقص منه البايكار ناقص الكلورايد. يعني هي المعادلة الحقيقية تاخذ الكلورايد والبايكار you combine them together وبعدين تنقصهم من الصوديوم. But the easiest way, take الصوديوم minus bicarb minus chloride, okay? And we'll take more examples about the anion gap when we talk about metabolic acidosis and alkalosis.